And then the most important part will be the pathologies and the parts of disease. Yeah, and at the end, we'll just give you a bit of advice for you too. Actually, before we get started, does anyone know who painted this? Any art heads? No? All right, anyway. On to actual content. We'll start with the brachial plexus. This is something you absolutely need to know. I obviously can't learn it for you, but hopefully you guys, the best way to learn this is to basically just draw it out a few times, like over and over. If you draw it out like 3 times, you'll remember it definitely in time for the exam. I'll quickly run through it for you. So you have 5 spinal roots. The top 2 will go to the superior trunk, middle will continue on by itself, bottom 2 will go to inferior trunk. They'll all divide into 2 divisions, anterior and posterior. All the posterior divisions go to the posterior cord. Top 2 anterior divisions go to the lateral cord. The bottom anterior division goes by itself to the medial cord. They all then split up into 2 again. Posterior will form axillary and radial. Lateral will form musculocutaneous and median, and medial will form the ulnar and the median. The median obviously is formed by 2 of the splitting offs of the lateral and medial cords. And then you'll see the M like at the end there, which I always point out to you in anatomy. We'll do this really quickly as well. So this is the bony structure. Basically, you don't need to know literally every single like nook and cranny of every bone, but you do need to know some of the main things. For example, the difference between the anatomical and the surgical neck, where the bicipital groove is for like Clinskills, deltoid tuberosity, radial groove, which is really, really important, which passes the radial nerve, and the condyles. Onto the elbow, it's a hinge joint, and you basically just need to know that the olecranon is part of the ulnar, and the ulnar groove passes the ulnar nerve. Sorry, this is going too quickly, guys. We'll try to get to the diseases. Last part, know how to examine all the carpal bones really quickly, especially for OSCEs next year. And you should definitely know where all of them are and which, like there are 2 rows, the distal row and the proximal row, and where they are. Also, you need to know listus tubercle, which is like this little bump on your radial, like tail. And you'll need to palpate that in your OSCEs as well. It's also there in Arabic if you want it in Arabic. For the vasculature, I barely even know this as well. So the only things that you do need to know is that subclavian artery turns into the axillary artery at the lateral border of the first rib. The circumflex arteries are important for supplying the humerus. The brachial artery will divide into the radial and ulnar arteries at the cubital fossa. And you need to know the palmar arches like exist, and that's it. And this is literally all you need to know for veins: cephalic vein, basilic vein, and the median vein. And that's it. These things we'll also run through very quickly. These are mainly here for completeness. The most important one here you do obviously need to know how to move your arm around. And you need to know which muscle groups do that, and then you need to know which nerves innervate those muscle groups. But the most important one here is obviously abduction, done by the deltoid. You can read the other ones later. Flexes are done by biceps, and extensors done by triceps. It's all pretty obvious stuff, and I hope you guys know this by now. And wrist stuff. Oh yeah, one note, you don't need to know every single muscle in the forearm, as in please don't learn every single muscle in the forearm. I know there are ones in DCs or whatever, and it's I don't really know. Just leave that and just know the main flexes and main extensors. And then you should know the intrinsic muscles of the hand. We'll touch on their innervation later as well. One thing to know is that lumbricals sort of do this motion. Actually looks like an L if you can't read. But yeah, just remember that the lumbricals do that, so it's important in ulnar, claw, and things like that. But we'll talk about that later as well. Okay, onto some actually important anatomy. I'm sure you guys in the tutorials have learned this thing where you put, no? Wow. All right, so basically look at the, do you guys do upper limb this year? Yeah. So, wow, our tutors went went really hard on this. So basically hold like two peace signs up and then put your right hand peace sign into your left hand peace sign. And you're basically looking at the back of someone's right shoulder. So you can look at the label thing on the bottom right. You have your humerus here, long head of your triceps here, and then teres minor and teres major. And these form three important spaces, the most important being the quadrangular space formed by that little squarish thing right there. And then that passes the axillary nerve and the posterior circumflex humeral artery. Those two are really, 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 really important structures where you need to know where they pass through. The lower triangular space passes the radial nerve and the deep brachial artery. But this is a really important space and it's really easy to remember how it works. Onto the cubital fossa. Hope you guys did this at least. So the borders are an imaginary line between the medial and lateral condyles. The medial border of brachioradialis and the lateral border of pronator teres. The main contents you need to know are from medial to lateral, the median nerve, the brachial artery dividing into the two ulnar and radial arteries, the tendon of the biceps, and the radial nerve. There are like mnemonics to like learn this, but I always forget like if it's medial to lateral or whatever. So it's best if you just learn this. Gosh, someone was really, really keen. Okay, last important space is the carpal tunnel. You guys will have definitely learnt this. There are 10 structures passing through the carpal tunnel. They ask you this like every week in tutorials as well. It's really a really small space, which is why you can compress the median nerve and get carpal tunnel syndrome, which we'll talk about later. But the 10 things are the 4 tendons of flexor digitorum superficialis, the 4 tendons for flexor digitorum profundus, the 1 tendon for flexor pollicis longus, and the median nerve. And we'll move on. All right, here's a question. My voice hurts, so you guys can read it. Okay, does anyone have an answer? How to C? Does everyone agree on C? So, as I said before, if you make your quadrangular space and the axillary nerve passes through it, and then when you get inferior dislocation, you can compress it and you can stretch it, you can damage it, and that supplies the deltoid muscle. All right, we'll breeze through this as well. Muscle innervation. This stuff here is also mainly for completeness, but you do need to know a few things about the innervation. The most important one is the axillary nerve supplies the deltoid muscle. You also maybe sort of need to know that the thoracodorsal nerve supplies the latissimus dorsi. The other ones, yeah. And these ones are actually pretty important. You know that the flexors of the arm are supplied by musculocutaneous, extensors, all the extensors are supplied by radial nerve. But the most important part is in the forearm. You definitely need to know this. The flexors of the forearm are all supplied by the median nerve, including the pronators, except for 2 things. Flexor carpi ulnaris, which flexes your wrist and puts your wrist into ulnar deviation, and the ulnar half of FDP, so moving the ends of your fingers on your 4th and 5th fingers. That's something you definitely need to know what the ulnar nerve innervates in the forearm. For hand, you should know the loaf muscles are done by the median nerve and its recurrent branch. Lateral 2 lumbricals, opponens pollicis, abductor pollicis brevis, flexor pollicis brevis. So they basically control the movement of the thumb. Everything else, all the intrinsic muscles, abduction, adduction, pinky movements, all done by the ulnar nerve. Move on. Myoterms. These are things that you just need to know. There's no real way to learn them. Also, a lot of different textbooks will say a lot of different things about myotomes. But you can either go with tally or you can go with more, which I've done here. It's pretty simple for the shoulder. So it's basically 5 and then 6, 7, 8 for all the movements. So there's 5, 6, 7, 8, 5, 6, 7, 8, and 5, 6, 7, 8. And then the flexion and extension at the elbow and the hand is actually much more complicated, but pretty much it's 6, 7, 7, 6, and then 8, 7. So if you do flexion, extension, flexion, extension, flexion, extension, it's 6, 7, 7, 6, 8, 7. That's something you need to learn as well. And the muscles of the hand, they're much easier to know, and they're all just T1. Okay, cutaneous innervation. You don't need to know much more than the 5 peripheral nerves that come off the brachial plexus. You should know that the radial nerve supplies the back of the arm and the back of the forearm. Axillary nerve supplies the shoulder. Musculocutaneous nerve supplies the lateral part of the forearm. I don't even know what supplies the medial part. It doesn't really matter. And the hand's a bit more complicated. The median nerve supply, sorry, we'll start with the ulnar nerve. Ulnar nerve supplies all of the lateral medial 1.5 digits. So that's not including the lateral side of the ring finger, but it supplies the palm and the dorsum of that part as well. Radial nerve does the back up until the fingertips, and the median nerves do everything else. So you should know that as well. As also does, the radial nerve also does the snuff box, which is important. Dermatomes. So for dermatomes, this is like a really old model. I think this is a 1933 model. We still use it. I don't know. It's probably wrong, but we do it anyway for clean skills. So basically, if you hold your arm up, thumb pointing up in the air, you have 4, 5 up to the elbow, and then 6, 7, 8 up to the elbow again, and then T1, T2. So you just go in a loop around your arm, and that's the best way to learn it. Okay, here's another question. Okay, does anyone have an answer? Anyone know? Just shout out the letter. D? Yep. Awesome. Well done, guys. You'll learn more about this in your respiratory exam and your respiratory section next year. In the respiratory exam, you have to test finger abduction for this as well. Okay, now onto the actually important part of this lecture. All right, fractures. We'll start with the humeral fractures. There are 4 ones you sort of need to know. One at the surgical neck, which will affect the axillary nerve, which passes through the quadrangular space, as we said before. Avulsion fracture of the greater tubercle, and because your lateral rotators are pulled off, it's going to lead to a medial rotation of the arm. A transverse fracture or a mid-shaft fracture. It's going to affect the, it should say radial nerve, but it should be radial nerve, and an intercondylar fracture. These 4 direct relations down in the bottom right I've written up are really, really important, and you definitely need to know these, and they'll help you in a whole host of exam questions. So at the surgical neck, it's very closely related to the axillary nerve. At the radial groove, it's very closely related to the radial nerve. The distal end, it's very closely related to the median nerve, and at the medial epicondyle, it's very closely related to the ulnar nerve, which passes through the ulnar groove. Yeah, again, transverse fracture should be radial nerve. Colles fracture, the most common Fouche fracture. which is a fall on an outstretched hand. And basically the distal end of your radial, the radius is pushed back, and then it gives that that dinner fork appearance. Thank you. I'm glad they drew the fork as well. And onto the scaphoid fracture. I'm sure you guys have heard the words avascular necrosis like a lot in shoots, or like retrograde blood supply. I think there's something with like the femoral head as well. But this occurs pretty rarely, but it's very hard to pick up on an X-ray because usually the fracture is very small. So if people come back for a second X-ray in like 2 weeks' time, they'll usually pick it up better because the bone will have been resorbed and things like that. Yes, the complication you need to know is avascular necrosis of the proximal fragment. This is pretty common, I'd say. Maybe it's in 30% of proximal scaphoid fractures. And due to the poor retrograde blood supply from the radial artery, you're not going to get enough blood to help your bones fuse together and recover. So this definitely requires surgical intervention. All right, on some nerve stuff. So we'll start with something I also love to talk about, winging of the scapula. Basically, the mechanism is a winged scapula is caused by paralysis of serratus anterior, and that's because serratus anterior can't hold your scapula against your chest wall. And that occurs from injury to the long thoracic nerve, which supplies serratus anterior. This comes off the brachial plexus really early, and you can get injury in like sports tackles, radical mastectomies, which involve like dissection of the lymph nodes, and knife injuries or bullet injuries, and that can lead to a winged scapula, especially if you're leaning your hand against the wall. Okay, onto the 5 peripheral nerve injuries. Axillary nerve injury. So the main causes, as we've said before a lot, are fracture of the cervical neck, shoulder dislocation, or sometimes incorrect use of crutches. The signs and symptoms are deltoid atrophy, as you can see in that bottom right picture, loss of sensation over the shoulder, as you can see in that little red patch there, and difficulty in abduction, as Karan had after he tripped over. Musculocutaneous nerve injury. Musculocutaneous nerve is actually probably the nicest named nerve in the body because it does exactly what it says. It runs down, supplies the muscles, it runs down, supplies skin. So an injury to it's pretty rare because it's in quite a protected position. But obviously, if you sever it at its origin, you'll get weakened flexion of the elbow due to it affecting like biceps, brachialis, and things like that, and slightly weakened flexion of the shoulder. That's because the biceps crosses the shoulder joint as well. And cutaneous, you'll lose sensation over the lateral part of the forearm. Radial nerve injuries in the arm. So you can cause radial nerve injuries in different parts of your arm, in the arm, or whether it's in the forearm or things like that. So knowing where you sever or where the lesion is going to help you make a diagnosis and work out what's wrong. At its origin, basically in the armpit, you can get honeymoon palsy, which is sleeping on someone's arm or someone sleeping on your arm, or Saturday night palsy. So like apparently it's like when you fall asleep in an armchair on Saturday night and your arm like rests against the armrest. I don't know what you guys do on Saturday nights, but so the deficit you'll get if you injure it in the axilla, paralysis, the complete paralysis of triceps, paralysis of all your extensors of the elbow, and paralysis of all your extensors of your fingers and the wrist. If you injure it at the radial groove, so from a mid-shaft fracture as shown in the picture, the deficits are similar to above, especially more distally, except you're only going to get weakened extension at the elbow because you're only going to be affecting one of the heads of the triceps and the other 2 heads won't be affected. And you get wrist drop, which is one of the really important things, triple exclamation mark, that you need to know. Wrist drop from radial nerve injury in the arm. Also going to get loss of sensation over the back of the arm and the back of the forearm. Oh yeah, any questions, guys, for anything? No? All good? Okay. Injury to the radial nerve in the forearm. The radial nerve splits off into a deep branch, and it also splits off into a superficial branch in the forearm. So injury to the deep branch of the radial nerve, which is also called the posterior interosseous nerve, is going to cause motor deficits, but no sensory deficits. So you're going to get finger drop, but you're not going to get complete wrist drop because some of your wrist flexors are still intact. And injury to the superficial branch, you get minor sensory deficits. Only a small sort of like coin-shaped area at the base of your first and second metacarpals, because the rest of your arm also has some other supply from ulnar nerve and median nerve and things like that. Here's a question. Okay, does anyone want to shout out the answer? B? Yes, well done. Wrist drop, damage to the radial nerve in the radial groove from a mid-shaft fracture. Very common question in exams. Onto median nerve injuries. These are actually probably the hardest. All right, guys. Thanks, guys. We'll start at the elbow. If you lose the median nerve at the elbow, you're going to lose flexion of the first 3 digits. So you can see the guy in the top right, or the drawing in the top right, is trying to make a fist. You're going to lose the lumbricals, and you might atrophy like the thenar muscles and things like that, things supplied by the median nerve. You're going to get weakened pronation, which is done by the median nerve. But the reason you can make your sort of 4th and 5th fingers go down is because, as I've said before, your ulnar head of flexor digitorum profundus is supplied by the ulnar nerve and not the median nerve. So they can still move, and that's how you get the hand of benediction, another triple exclam. Anterior interosseous syndrome, which is a branch of the median nerve, which affects only some of the muscles in the forearm, not all of them. So the thenar muscles are unaffected, so you can move your thumb, except you can't sort of flex your interphalangeal joints. So when you're trying to make an OK sign, you can't bend your fingers enough, and you're just going to be making the pinch sign instead. And for sensory loss over where the median nerve supplies, lateral 3.5 fingers, side of the ring finger, and the nail beds as well. Pronator syndrome, exact same as median nerve injury in the arm, except you get a lot of pain when you're doing movements which require pronation. And for carpal tunnel syndrome, another is the compression of the median nerve through the carpal tunnel, which has the 10 things running to that really small space. So you lose your thenar muscles, you have loss of strength, loss of coordination. You might suddenly find it difficult to like do up buttons or write properly, and you're going to start getting atrophy of your thenar eminence. You don't get complete loss of sensation over the palm, whereas you normally get like tingling or like paresthesia over your fingers, because the palmocutaneous sensory branch comes off before it goes to the carpal tunnel, and so it isn't compressed inside of the carpal tunnel. So you lose sensation over the fingers, but not over the palms. Ulnar nerve injuries higher, so posterior to the medial epicondyle. It's injured in fractures if you're like smashing like your funny bone. Sensory deficit to where it supplies in the hand and the fingers, and motor deficits as well. You can get weakening of wrist flexion because it does flexor carpi ulnaris. And when you're trying to flex your wrist, it's going to move to one side, to the radial side. You can get hyperextended MCPJs, as shown in the photo. So that's because of your loss of your lumbricals and your extensors are unopposed in their action. Absent flexion of the distal interphalangeal joints due to paralysis of the ulnar half of FDP, and weakened intrinsic muscles. So that means like abduction, adduction, things like that. And you get ulnar claw. Ulnar claw actually looks quite similar to the hand of benediction. The thing to remember is that for ulnar claw, these metacarpophalangeal joints are hyperextended, and in the hand of benediction, they can be flexed. So often it's hard to tell, but just know that at this joint here, for the fourth and fifth fingers, they're hyperextended in ulnar claw, they're flexed in the hand of benediction. Ulnar nerve injury and Guillon's tunnel. That's compression sort of in the sheath that the ulnar nerve runs through between the pisiform and the hook of the hamate. And it's similar effects, but without the forearm signs. And here's where I want to talk about the ulnar paradox, which is pretty complicated. You probably don't need to know this, but it's good to know as well. So basically the saying is the closer to the paw, the worse the claw. You would normally expect an injury to a more proximal injury to be like worse and more debilitating, and it might like look worse, except the ulnar claw looks much worse when you have an injury at the wrist instead. I'll try to explain it the best I can. If you start with ulnar claw with an injury at the wrist, your lumbricals are pushing your lumbricals aren't working, so you have extended MCPJs. However, as the lesion moves further and further up, more of your forearm is paralyzed. So if you go further towards the elbow, your forearm becomes more and more paralyzed, and as it becomes more and more paralyzed, it loses more and more of its power, and so it's pulling on your fingers less and less as you move further up. So an ulnar claw which doesn't look as bad means that the injury is at the elbow. An ulnar claw that looks much worse means that there's an injury at the wrist. And that's because your forearm isn't paralyzed when you have it at the wrist, and it's pulling those fingers down. Does everyone get that sort of? Yes? See someone nodding? All right. All right. Question. Yeah, okay. I'll explain that after I do this. Does anyone have an answer? All right, I'll get one of you to shout out the answer if you guys know it. A, B, A. All right, yeah. So it's A. It's hitting the ulnar groove causes the sensory deficits in the fourth and fifth digits. I just got a question just then asking, what was it again? Sorry. Yeah, okay. So your lumbricals do this motion, right? And then when they're paralyzed in the fourth and fifth fingers, your extensors are going to be unopposed in their action, so that your extensors are too strong for the paralyzed lumbricals, which means that they're going to be pulling and causing that. A lot of these deficits where you get paralysis of muscles wherever in the body, a lot of times you have flexor groups and extensor groups. If the flexors are paralyzed, your extensors are going to be like working much stronger, and there's going to be flexion at that joint, whether it's the knee or whatever. And when your extensors are paralyzed, it's going to be vice versa. So that's something to know when you're talking about really deformed or like oddly shaped joints in weird positions. Okay, those were the important things. I can guarantee you, I'd say 80% of upper limb exam questions would have been on all these things right here. But I'm going to quickly run through some other things, and I'm not going to go through all of them either. So brachial plexus injuries, if you have a superior brachial plexus injury from sort of the angle widening between your head and your neck, like the breakdancing guy in figure A, you're going to get a waiter's tip position, which is basically medial rotation of the arm, and your palm's going to be pointing backwards. Inferior brachial plexus injuries from widening of the angle between your torso and your arm, like someone catching their fall like on a tree branch or something like that. You're going to get signs and symptoms similar to ulnar nerve damage, because obviously the medial cord supplies the ulnar nerve and so on. Axillary artery aneurysm. Do you guys know what aneurysms are yet? Sort of expansions of the blood vessels, because the axillary artery is very, very close to the three cords of the brachial plexus. An aneurysm can cause compression, it can cause signs of sensory loss or motor loss and things like that. When you're dissecting the axillary nodes, you have a chance of injuring the long thoracic nerve, which causes paralysis of serratus anterior, which causes winging of the scapula. You can also injure your thoracodorsal nerve, which will paralyze latissimus dorsi. Again, these aren't super important. They're pretty low yield. Shoulder dislocations, most important inferiorly, can compress the axillary nerve. We had a question on that before. Shoulder separation, rupture of the ligaments holding the acromioclavicular joint together, as you can see in the top photo picture. From a hard blow to the shoulder, rotator cuff injury. I think you guys had like an ICL on this. Do you guys have that? Yeah, rotator cuff injury. Basically, a lot of the movements where like your arms above your head, like swimming or like throwing or like racket sports, things like that. You can get degeneration of the tendons, causing pain and causing weakness. Calcific supraspinatus tendinitis. Basically, that's calcium deposits, crystals in the tendon of supraspinatus, and because it's very, very close to the subacromial bursa, as you can see in the bottom photo, when you're like holding your arm up, you basically rub those crystals against the bursa and they can get inflamed and irritated. And that causes the painful arc between 50 and 130 degrees. That's one of the tests you do for playing skills. More pathologies, elbow dislocation, driving a flexed elbow really hard into something. You can push your olecranon back. And also subluxation of the radius. Do you know how like when you pick kids up by the arms and wait, sorry. Do you know how like when you were a kid, you sort of like swung between your parents' arms? Is that a thing? Or is that just me? Okay, yeah, so that was a thing. Because they have weaker annular ligaments, so that holds the radial head into the against the elbow. That can like sublux or like slip out, and you can cause radial dislocation. Yeah, I don't like to throw kids around. Olecranon fracture. When you smash your olecranon against something pretty obvious. Student's elbow is something you examine for, I think, in clinical skills as well. It's just compression over the elbow bursa, and that also can occur from like repetitive extension motions. It's also called dart thrower's elbow for obvious reasons. Biceps tendon rupture. I'm sure you guys have all seen videos of like someone's tendon rupturing. So there's like a really loud popping noise, and then the muscle basically just curls up into a ball. And that's very obvious and very easy to diagnose. Lateral and medial epicondylitis. That's tennis elbow and golfer's elbow. That's the tennis backhand. I always got confused because I was like, I don't know, is it a tennis backhand, tennis forehand? The tennis backhand, and it's a golfer's swing. So that's lateral epicondylitis for the tennis elbow and medial epicondylitis for golfer's elbow. Last part. These are very, 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 very low yield, except for maybe mallet finger, which you look for in your upper limb MSK exam. Do you know how when you're like playing baseball Saturday, as you like normally do, and you're like make a baseball dive with a baseball base and you hit your baseball finger against that base, you get a very forceful a flexion of the distal interphalangeal joint and rupture that tendon, and you get mallet finger. Other things, blah, blah, blah. You'll learn most of these next year. Yeah, I'm not going to go through them now, so you won't need to know them. Last question. All right, does anyone want to shout out the answer? Anyone just shout out the letter D? I'm hearing D, yep. Supraspinatus does the first 15 degrees of abduction. So often when you see people with damaged supraspinatus and they're trying to get their arm up, they'll sort of like lean to the other side to help it get up before the deltoid takes over. So yeah, this is a summary of the things that you have to know pretty much. You need to know the brachial plexus. You should definitely know what the names of the bones in the arm. You need to know those spaces. You need to know myotomes. You need to know dermatomes. And most importantly, you need to know, thanks guys, you need to know the injuries to the 5 peripheral nerves and how they present and where those injuries might be. Anything else, I'm probably going to say low yield. Yeah. All right, yeah, I'm just going to quickly touch on advice for year 2 because this was much more useful for me in last year's revision lecture than any of the content that I learned. Okay, I'm sure you guys have seen or heard of these textbooks before. I really, really encourage you to take a look at them. So Moore and Daly, I got all those blue boxes, like those like snipping tools out of Moore and Daly. They go through the anatomy and then they go through like the clinical like pathologies you might see for all parts of the body. Really strongly encourage it. For the second book, Talley and O'Connor, we base our entire clinical skills like curriculum around this, like I think. So have a read of that. If you're confused about any clinical skills things, you can always get the answers in Talley and O'Connor. You don't have to buy these books, by the way, just borrow them. And Guyton and Hall for medical physiology. Obviously, there's not much physiology for you this year, apart from muscle phys, but like literally 99% of Chris Wright's stuff is taken in order, like verbatim from this book. He really should put it like as a reference, but you're going to need this for like renal, endocrine, resp, cardio phys as well. Yeah, so it's really important. It's really good to get a PDF of it. I think it's online on the Med drive. Additional resources. MSD manual professional version. I'll get you guys to like Google that right now because Nadita showed it to us in class and it's literally the best thing that's ever happened ever to me. It is a Google for medical diseases pretty much. So any disease that you want to type in, it'll give you in order, like what it is, pathophys, signs and symptoms, treatments, like management, epi, just all for the disease, and that's it in a short, like condensed web page. I really encourage you to like bookmark that. ePharm is really good for pharmacology. Australian Medical Handbook, really good for pharmacology as well. Anatomedia is like okay, I guess. And Netter's flashcards. Does anyone have Netter's flashcards here? Some people, yep. So I'm sure you guys could vouch for them. They're like good value, like $40, and you can get like 200, 300 sort of flashcards for anatomy all throughout the body. Oh yeah, 2 actual pieces of advice. I know a lot of people say like stuff like have fun or like make friends or like whatever. But I want to give you actual pieces of advice for next year. The first one I got from one of the revision lectures last year, and it was a very nice piece of advice. So prepare for anatomy tutorials beforehand, before you go in. Anatomy tutorials, your 4 hours of anatomy every week, are really good for consolidating information, not that good for learning new information. So sometimes when like people in imaging just like have no idea what they're doing, they pretty much just wasted an hour in imaging. So it's really good to take a look at the anatomy beforehand. You don't really need to do it for this year, it's pretty simple, but do it for next year. And that way you're not wasting your time in anatomy and you're learning like double. And revise them afterwards. You guys still get questions, right? Like in your tutorials, like 4 or 5 questions that you work on. Yeah, I really encourage you guys just to like write up fully like fledged answers for all of those questions, because all the exam questions are going to be based on those tutorial questions. So do that for your upper limb, do that for your lower limb and things like that. And lastly, learn and revise your OSCE systems throughout the year instead of like leaving them to the last minute like I'm doing. And yeah, good luck. Message me on Facebook if you need. Chuck me an email if you want to, but don't message me on email. Enjoy the time you have in free 20 years. And yeah, lastly, hope you guys, on a more personal note, look out for each other. Med can be pretty hard, especially this time of the year.